Hello and welcome to the Common Part B Pulmonary Disease Claim Rejections and Denials webinar. I'm Mary Mucko. I'm a member of the WPS Provider Outreach and Education, or PO team, and I'll be your presenter today. I'm joined by my friend and teammate, Karen Curtis, who will assist with some of the behind-the-scenes help. This webinar is for those people who are wishing to learn about the most common rejections and denials on Part B claims submitted to WPS by pulmonary disease specialist providers. CMS requires that Medicare administrative contractors like WPS include this education to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar today is based on actual Part B claims data. The presentation is available to download from our live events webpage. The page address is in the chat. You may take time now to download it if you've not already done so. We will record this session, and barring technical issues, we'll post the recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current, or we otherwise determine we need to remove it. Now, if you have questions, please put them in the chat. I will answer questions as time permits today, but if I don't get to your question, I will email the response following today's webinar. If you have a question on a specific claim, one that is currently in processing, one that actually already denied, or one that was otherwise sent to WPS, I cannot answer specific questions relating to a specific claim. You must contact customer service so that they can access the claim edit trail in our system and help you with the information that you need. We include this disclaimer in all our live events. This presentation is for educational purposes only, and I did make every effort to verify that the information I'm going to talk about is current and accurate. That includes the presentation materials, but it is subject to change. It is on the CMS website where you're going to find rules, regulations, and such that determine final coverage. Those rules and laws, rulings will always prevail. CMS prohibits recording of our presentations for profit-making purposes, so we do ask that you refrain from recording the presentation. This would include taking any screenshots. We will create an encore of the presentation, and you may use that for any future reference. So here is the agenda for today's webinar. This is exactly what the advertisement stated. So today my goal is to share with you and reveal the most common rejections and denials for pulmonary disease claim submissions to WPS. I noted that on the registration, several of you asked some questions that weren't pertinent to the specific topics that we're discussing today, but that information is important to us. That's the kind of information we like to have to plan future education. At the end of today's presentation, you'll have an opportunity to complete a brief survey. If you would include any suggestions for future education when you complete that brief survey, we'll put that on our list of items to consider or topics to consider in the future. But today, just as this slide shows and my advertisement stated, I'm going to define rejections and denials. They're very different. I'll reveal the reasons for rejections and denials based on the data that I pulled and analyzed. I'm going to discuss ways to fix and avoid those most common rejections and denials. And along the way, I'm going to be providing you with many, many resources, many of which are embedded in links in that electronic handout that you're able to download from our live events webpage. Now, this is a lot of information, I realize, to share in 60 minutes. I'll be moving rather quickly through the slide deck, and I may ask you to review some of the information following this live presentation, mostly those resources that I talked about. Um, if you have any questions, again, I'll tell you later how you can send them. For right now, though, you can place those questions into the chat. Karen is monitoring the chat, and we'll ask those after my prepared remarks if time allows. One more thing before we get started is this CPT copyright notice, and this is based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data. I've included this copyright notice in the presentation materials that you're able to download. Your continued participation in this presentation today infers that you agree to the terms of this copyright notice. Now, in order for me to discuss rejections and denials, I need to provide a bit of information about the claim process itself. Based on a law that requires it, most providers submit claims electronically. There are reports that confirm claim receipt at WPS, and they also report more specific information about the claim data requirements. Now, one of these reports is the 276-277 report. The Medicare 276-277 companion guide was prepared by our electronic data interchange, or EDI staff, and helps claim submitters understand the claim requirements and know when they need to contact us, correct something, or resubmit the claim. Claims that move past those pre-pass edits will generate a remittance advice, also referred to sometimes as the RA. Sometimes we simply call this the remit, others simply call it the notice. There are two formats for the RA, the electronic remittance advice, or ERA, and the standard paper remittance, or the SPR. Now, with few exceptions, most providers are going to receive that electronic version. The RA provides important information to the provider. For adjudicated claims, you can find information about such things as adjustments, denials, missing items, refunds, and even sometimes offsets. When looking at a remit, you're going to find various reason and remark codes. These are typically in an alphanumeric format. When claims pay differently than they were billed, a claim adjustment reason code will appear on that remittance notice. Sometimes a remittance advice remark code will also appear. And the remittance advice remark codes really actually expand on those details that are described by a reason code, and they do so to provide more details about the adjustment made to the claim. Another type of code on the remittance advice is a group code, and group codes assign financial liability for any unpaid balance on the claim. A CO group code stands for contractual obligation, and this means that the provider is liable and cannot bill their patient. A PR group code on the remittance advice means that the patient is financially responsible. Now, WPS hears a lot of comments about these codes, reason and remark codes. Providers often state that the codes are too cryptic. Sometimes we hear comments such as the fact that these reason and remark codes contain outdated acronyms. While we would like to help, another contractor, not WPS, maintains these reason and remark codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to suggest a change to a reason or remark code, anything on those code lists, including those code explanations. Now, I need to describe or explain to you the difference between a rejection and a denial. And as I said earlier, these are really very, very different things. I find myself sometimes getting tripped up and calling a rejection a denial or vice versa. And I'm usually pretty quick to correct myself because I've gotten used to doing that. But it's really important that you recognize the difference between the two, because depending on whether the claim is rejected or denied will depend on your next action to take. So this slide rather provides for you a side-by-side comparison. On the left is rejections, and a rejected claim is called by CMS or deemed as unprocessable. We can't actually process the claim. It's not adjudicated. It's returned on the front end. The reason it's returned is because something is invalid, incorrect, missing, invalid format, and so on and so forth. There are no appeal rights because that rejected claim was never adjudicated. What you need to do is fix it and resubmit it. And what I mean by that is submit a new claim, not a corrected claim, submit a new claim. Now, when you look at a remittance advice and you see an MA130 and a CO16, not 15, it's a CO16 code on that remittance advice, that should be an indication to you that this is a rejected claim. The patient is not liable for payment. You need to fix it, resubmit it. A denial, on the other hand, represents a claim that has been adjudicated by the MAC, the Medicare Administrative Contractor. The reason for denial could be one of multiple things. Perhaps it's based on a law that Medicare doesn't cover something. It's a statutory requirement. Maybe we denied the service because it didn't meet Medicare's medical necessity requirements or criteria. This would include any utilization parameters or frequency guidelines. Those are all bundled into that medical necessity category. There are other claims that deny due to eligibility. It could be eligibility of the patient, or it could even be that the provider was not eligible when that service was performed. On a remittance advice for a denied claim, you will see an MA01 code most times. There are some exceptions, and what that particular code does, or that Remark code does, is provide appeal rights. It will tell you you have the right to appeal. You need to submit it in a timely manner if you wish to request an appeal. Now, for denied services, of course, the patient liability would be determined. Next, during these slides, I will discuss whether you'll need to correct or appeal the claim. And this is really what I was getting at earlier when I said that there is a big difference between a rejected claim and a denied claim. Let's talk about that. After reviewing the remittance advice, you're going to need to choose the action that you need to take. For an unprocessable or rejected claim, you'll need to fix the error and resubmit that claim to Medicare. Send a new claim. If the claim or even a claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service. You might use the clerical error reopening or CER process to fix clerical errors, and CMS defines clerical errors as human or mechanical errors on the part of the party or the contractor. Another action to consider for a denial is an appeal. Your remittance advice will provide appeal rights if there are appeal rights, and in most cases you will see that MA01 on the remittance advice that provides the appeals right. I'll discuss appeals just a little bit later in this webinar. Registered users can use our SecureNet Access portal, our self-service tool called SNAP, in order to render or request a clerical error reopening or to request an appeal. And these are those self-service tools that really do offer our providers the most efficiencies and time saving. Our portal user manual provides illustrations and step-by-step instructions on how to use these and other portal features. For claim denials, most often you can request an appeal. I mentioned that earlier. The purpose of the appeals process, of course, is to ensure the correct adjudication of claims. Now, physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by the MACs. The beneficiary or their representative may request an appeal on any service processed for them. Providers and suppliers, however, may appeal services for which they accepted assignment. And for unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary needs to sign an authorization statement. And in addition, providers or suppliers can also request an appeal, that first level redetermination on an unassigned claim, excuse me, if Medicare denied the service as not reasonable and necessary, or in those cases where the provider or supplier billed in excess of the limiting charge. If that's the case, of course, the provider or the supplier would need to refund any fees collected from the beneficiary. The first level of appeal is the redetermination, and that is the only level of appeal that is rendered by a MAC, which is a Medicare Administrative Contractor. WPS is the MAC for jurisdictions 5 and 8. Timeframes apply to each level of appeal when submitting that appeal request, and additionally there is a minimum amount in controversy that does apply to two levels of appeal, level 3 and level 5. You can combine like denials on more than one claim in order to reach that minimum amount in controversy. You can check out how to appeal a claim determination on our website. This particular slide links to a resource that's available that will tell you how to appeal a claim determination, step-by-step instructions for doing so, what you need to submit, and so on and so forth. And then the other item that I've linked to, or resources that I've linked to or embedded a link to on this slide, is one of my personal favorites that I like to share with providers when I talk about the appeals process. It is updated annually, and it looks like what you see right here on this slide. I actually copied and pasted the CMS fee for service appeals process flowchart onto this slide. You can see over on the right hand side there is the standard process for original Parts A and B fee for service Medicare, and there's the expedited process that applies for some Part A only services. So this particular flowchart shows you those 5 levels of appeal following that initial determination that's made by the MAC. So the claim is initially processed, that is the initial determination, and then the 5 levels of appeal follow. The first level of appeal, of course, is that redetermination that I talked about, the only level of appeal rendered by the MAC. You can see those time frames that I talked about. You have 120 days to file the first level of appeal. Once filed, the MAC then has 60 days to render their decision. Once the decision is made and notice sent to the provider and beneficiary, you have 180 days to file the second level of appeal. That contractor, the qualified independent contractor that renders the reconsideration, has 60 days to render their decision. So on and so forth. The third level of appeal is the Office of Medicare Hearings and Appeals, sometimes referred to as the Administrative Law Judge hearing. That is one of 2 levels that has that amount in controversy. And if you look right at that third level appeal here, you will see the AIC, which stands for amount in controversy, is greater than or equal to $190. Their fourth level of appeal follows that Medicare Appeals Council, and then the fifth and final level of appeal is judicial review in in federal district court, and that amount in controversy for that level is greater than or equal to $1,900. I mentioned to you that this appeals process flowchart is updated annually, so if you're coming to the end of the year, make certain, or into the new year rather, into a new calendar year, make sure you're checking the date at the bottom of this to see what this chart reflects, or the current chart that's posted on CMS's website, because you'll want to make certain that those amounts in controversy that can change from year to year have been updated for you. All right, this brings us now then to the next portion of today's webinar, and this is that section or portion of the webinar that really focuses on that Part B claim data. Today's presentation does not include any Part A claim data. It was advertised as pertaining to Part B data. I used a tool that we call the data dashboard in order to pull the data that I plan to share with you today. And the data dashboard is an interactive tool that was designed by one of our data analysts in our Insight department. Insight is just simply the name of the unit at WPS that's responsible for all things data, mining data, looking at data trends, of course, among other tasks and responsibilities they have. So they created this dashboard so that people like Karen and me can go out and pull this information as it's needed in order to prepare education for our provider community. Now, this data dashboard is one that we can look at in different ways. We can look at different kinds of data. We can, in an instant, folks, just by pushing a button, view rejections or denials. We can drill down by states in our jurisdiction. We can even drill down as far as a county. I know sometimes when I'm invited by a partner organization to do a presentation for them, I will pull data that's specific to that particular county in which that particular partner resides, or is located, I should say. Sorry there, I clicked a little too quickly. So I want to talk about some of those data slicers that I used to pull the data. This particular slide here, and I got ahead of myself because I moved my my scroll on my mouse here. We can pull data by reason, why did something deny or reject? We can pull by specific CPT code or look at a list of CPT codes. We can even look at specialty. And for today's webinar, just as I advertised, it's pulmonary disease. Pulmonary disease is specialty 29. For those of you that are unfamiliar with what a specialty code is, I'm going to explain that in just a minute. But in addition to looking at the data this way, we can also view data trends by looking at that dashboard. So the data that I'm sharing today is all states in our jurisdictions, 5 and 8, Iowa, Kansas, Missouri and Nebraska, Indiana and Michigan, all of those combined. I'm looking at specialty 29 claims, or that's what I did look at. This is a 2-digit code that's assigned to WPS providers when they enroll. Now, during enrollment, a provider can self-designate their primary specialty. They can also, some providers, not all, can designate a second and third subspecialty. But it is only the primary specialty, the one self-designated by most providers, that is used during initial claim processing. Now, of course, there are some situations where a provider will request an appeal and stipulate their secondary specialty in order for Medicare to make payment. But specialty code 29 is one that is assigned. CMS maintains that list of specialty codes, but specialty 29 is assigned for pulmonary disease. So I pulled pulmonary disease specialty claims, submission dates November 1, 2024 through January 31 of 2025, and that the data was last refreshed or pulled or updated, if you will, on February 10 of 2025, not 2024. So here then, folks, I'm revealing the most common reasons why Specialty 29 claims for WPS claim submissions, Specialty 29 pulmonary disease occurred. So this is based on facts, or that data that I pulled. I always like to say the data doesn't lie. The number one reason Specialty 29 claims are rejected, not denied, is that the claim is missing or has an incomplete or invalid ordering primary identifier. In other words, the ordering physician number or provider number was missing, incomplete, invalid, maybe it was keyed incorrectly, so the claim was rejected on the front end. It cannot adjudicate. It's being sent to the provider needs to fix it, resubmit it. The second most common reason for rejections, your specialty, is that the claim has been forwarded to Palmetto. Palmetto is the Railroad Retirement Board contractor. For those beneficiaries eligible for Medicare that are retired from the railroad, their claims are processed by a specialty contractor known as the Railroad Board contractor. It is Palmetto GBA. In this case, WPS forwarded the claim for you because there is an agreement for us to do so. For certain rejected claims, if there's a trading partner agreement that exists, that claim will be forwarded. And in this case, 128 claims were forwarded to Palmetto during that 3-month period. Those numbers that you see following these rejection reasons do represent the number of claim lines rejected. Third most common, patient insured name on the claim and the Medicare beneficiary identifier do not match. This typically happens because the name doesn't match the number, and here's the reason why. If the Medicare beneficiary's Medicare card shows that the name has a middle initial, or that there's a middle initial posted or published on that card, appears on that card, that Medicare card, it needs to be placed on the claim exactly in the same manner. If there's a middle initial on the patient's card, it needs to appear that way on the claim. And that's typically what happens here, 80 claim rejections, claim line rejections. Here's another one. Claim must be submitted to the Railroad Board, 71. Well, the difference between this reason and the second most common reason for rejection is that 128 claims were forwarded to Palmetto because of that trading partner agreement versus the need for you to submit the claim to the Railroad Board on your own, which is that fourth bullet, 71 claims. Similarly, claims should be sent to United Mine Workers of America for processing, 64 claims. WPS would not process the claim for that individual who, got to go back here, was a coal miner and has United Mine Workers of America that needs to be processing their particular Medicare claims. I'll show you a tool later when I talk about resources that will help you determine to which contractor you need to send a Medicare beneficiary's claims. I thought it would be interesting not only to tell you the reasons why Specialty 29 pulmonary disease claims are rejecting, but also to tell you what are the services that are most commonly rejected. So that's what I'm doing here in the next few slides. The 99232, of course, is an evaluation and management service with moderate medical decision making. 293 claim lines rejected during that time period, and you can see the reasons I've included there. The only one that I haven't talked about already that didn't make the top 5 most common rejected reasons for rejections is invalid or missing modifier. In that case, what you need to do is look at your claim that included CPT 94729, which is your pulmonary diagnostic testing and therapies. It's an add-on procedure code. You need to look at it and determine, was there a modifier reported, and if so, was it invalid? Or Is a modifier required for this procedure on this day based on the information on the claim? Is it invalid or is it missing? I'll show you later where you can find resources to determine how to use modifiers correctly. 99233 is that moderate evaluation and management service. I got ahead of myself there just a little bit. This is the second most commonly rejected service or CPT code for your specialty. Evaluation and management with that moderate medical decision making, and the reasons are shown here on this claim. All of them match the top 5 reasons for claim rejections for your specialty, things we've already talked about. 94060 is spirometry, being rejected 267 claim lines. Again, all of these common reasons for rejections are the same as those we've already talked about. That invalid or missing modifier, of course, didn't make the top 5 all around, but for this CPT code, it did. The 99232, similar to this, I believe, let me just check something here. 233. I'm sorry. I apologize and said this was moderate decision making. This 99233 code is for the high level, of course. I apologize for misspeaking there. Now we're talking about the 99232, which is the moderate medical decision making. Again, these are the reasons why your claims are rejecting. 99232. Claim must be submitted to Railroad, or we've already submitted it there for you. Oh, here's a new one. The place of service conflicts with the procedure code. Submit a new claim. Typically, this would mean, of course, that that 2-digit place of service code on your claim cannot be reported with this particular CPT code. You'll want to take a look at the CPT code, make sure that the description is correct, make sure that the place of service that you are reporting on your claim is one where that particular service is valid. We do have a place of service code list on our website. I have included that in your resources later in this presentation. Just as I advertised that I would give you all of those resources so that you can avoid these in the future, or correct them if needed in the case of a denial or even a rejection. Another thing you can do here for this particular rejection reason, place of service conflicts with procedure code, is you can call customer service and you can ask them, is place of service 12 valid for CPT code 12345? Of course, I'm just pulling these out of the air. What you can't do is say, the beneficiary was seen in their home and we did an XYZ. Can I code it this way? That's coding advice, and CMS prohibits us from offering coding advice, but you can call customer service and you can ask them, does your system accept place of service, and give us the code, with CPT code, and give us that code. Okay, so kind of magic words there. Does your system accept? Does it mean it's payable? No, that's not what we're saying. What we're saying is our system will accept this place of service with this code. The claim would, of course, need to be adjudicated based on all of the other information on that claim. 99214 is your established office visit with moderate level medical decision making. Here's a new one popping up. The facility and lab name and address or PIN is missing from the claim. You need to make certain that you are looking at the claim form instructions, both the electronic and the paper claim form instructions, and making certain that you're putting all of the information on the claim that's required. And I'll show you a crosswalk in just a little bit that tells you item by item what you need to include on that claim. But in this case, the top reason for rejections for this code is that the facility or lab name and address or PIN is missing. The other reasons here are those that we've already talked about. All right, I mentioned to you earlier that we can look at trending. We can look at reports, and again, just with a click of the button, we can change those data slicers, if you will. Slicers are, if you can envision an Excel spreadsheet with a drop-down menu. You pick what you want to see. Those are slicers, okay? So we can look at trending also. And in this case, I chose rendering physician number invalid missing. Submit a new claim. 37 claims rejected, or claim lines rejected the current 3 months, 11 the prior 3 months. This was a 26 claim increase and represents a 236% change. So just at a click of the button, we can look at these reasons and remark codes and such, reasons why claims are rejecting, to see if we're trending in the right direction. This helps us identify, do we need to write a news item? Do we need to write a resource for our website? Do we need to host a 60-minute webinar to talk about this problem? We can look at this for this current 3-month period and the prior 3 months, and then 3 months from now, when they refresh that data in that data dashboard, we can look at the new data and so on and so forth. So some good stuff. All right, let's take a look at those most common reasons for denials. Specialty 29, claim line counts are included here. Payment included in another service received on the same day, 1,408 denied lines. That's a bundling situation. We'll talk about bundling in a little bit, where you can find information to avoid those types of denials. Most of all, you're going to look at those National Correct Coding Initiative edits, and we'll talk about that in just a little bit when I talk about those resources in more detail. Look at the next one. This is a duplicate charge. 1,043 claim lines denied for that reason. And let me just say that for duplicates, there's different types of duplicate denials. So the simple fact that the second most common rejection or denial, caught myself there, folks, the second most common denial reason for pulmonary disease during that 3-month period was that type of duplicate denial, doesn't mean that there weren't other duplicate type denials made. Let's put a dollar amount to that. Let's just for the sake of making it easy, let's say it costs $1 to submit every single one of those claim lines. That's $1,000, right? Okay, so what if it costs $1,000 for Medicare to process it? And I'm just pulling these numbers out of the air. Think about the money that it costs submitting duplicate claims and charges. If you or your billing service submits on a payment cycle, automatically every 30 days, stop doing that. It's abusive, and abuse can be viewed as fraud if it continues. We need to do everything we can to check the status of the service before resubmitting a new claim for that service or a duplicate claim. We need to avoid these. This has been problematic for as long as I've been working in Medicare, but that certainly doesn't mean that we stop educating about this. The next reason, the third most common reason why claims are rejected, is collection of fee-for-service during periods of managed care. What we're talking about here, folks, is that this particular beneficiary has chosen a Medicare Advantage plan or a managed care plan over or instead of, in lieu of, original or traditional Medicare. So the claim needs to go not to WPS, but to that managed care plan or that Part C plan, Medicare Advantage plan. Next, not covered when performed, referred, or ordered by this provider. 647 denials. Check the ordering, referring, or providing numbers and make certain that they correctly identify who's ordering, performing, or referring the service. Be aware of which services can be rendered by what kind of providers, and so on. 647 denials. Next one, claim must be sent to EGHP first, and that's exactly how it prints out. So I use the acronym here, but this acronym stands for Employer Group Health Plan. This means that Medicare is the secondary payer. So you need to submit that claim to the Employer Group Health Plan first, so that Medicare can then consider payment on a secondary basis. 99233 is that E&M service, high level, subsequent hospital inpatient or observation care code. You can see that with the exception of the third bullet, we've talked about these denial reasons already. Expenses incurred after coverage terminated. So that one kind of describes itself, the reason why. Check your date of service. Maybe the date of service was entered incorrectly. Maybe it was entered under a provider number that's no longer covered. so on and so forth, that termination or that coverage has terminated. 99291, that is your critical care code. Again, duplicate, managed care. Look at the third bullet though, service or the units of service are exceeded. That, folks, is that MUE, the Medicare unlikely edit, that this is failing. The units of service reported on the claim are in excess of the MUE. You can check the MUEs in the National Correct Coding Initiative edits, and I'll show you where you can find those in just a little bit. Now, if you bill in excess, it is appealable, but you would need then to submit your appeal request and ask Medicare to consider payment for those units of service that exceeded what you billed. You'd need to provide, of course, the supporting documentation to support payment for those services. 99214 is an E&M service. Again, nothing new here. Other than how this is explained, this denial reason. Medicare is secondary, send claim to primary payer. So again, all of these we've talked about. The 94,760 is pulse oximetry. Medicare does not pay separately for this service. Do not bill the patient. For services that are not covered, never covered, you don't need to submit. For services that are sometimes covered, you would need to submit, of course, but for this service, the 94,760, Medicare will not pay it separately. Referring provider not eligible and missing, incomplete, invalid ordering provider rounds these out. G2211, that is your visit. It's an add-on code, that visit, the complexity code, add-on code for visits for those single serious or new or established complex conditions. Those are the reasons why these services are being rejected. The G2211 is an add-on code that can only bill for with other certain services. In this case, we denied 375 claim lines because it was reported with a service that it should not be reported with. And we have education available about the G2211 on our YouTube channel, quite a bit of it, some great resources available for you there. Duplicate. Procedure must be billed with a primary service. This is an add-on code, so you need to make certain you're also billing that primary service when you're billing the add-on code. And finally, not covered when performed, referred, or ordered by this provider. Here is the trending example for specialty 29 providers. Try to pull something over here for you. This one is a denial that's really been kind of kicking us in the pants, folks. Timely filing. 234 claims, current 3 months, 4,282 the prior 3 months. There's a 194 claim decrease. This is what we want to see, folks. Wonderful. This is a minus 45% change. We have identified timely filing as problematic. Providers continue to file claims more than 1 year after their right to file is expired. And we've done some education on it, and this just kind of backs us up and shows the difference that education is making, especially for this particular specialty. Now, of course, we'd have to look across the board to see how other specialties are affected too. We do have a timely filing resource available on our website. It explains that waiver process if you believe that we should have made payment beyond that timely filing. If you believe you qualify for the waiver, it tells you what to do. And it also explains that the simple fact that another payer paid first and then took back their money, thought they were primary, but they really weren't. That article or that resource on our website, and I'll show you the resource in a couple of minutes, not the resource, but the link to it, really tells you that CMS doesn't allow WPS to say that's okay. It is in the internet-only manual that explains that when another payer pays first and takes back the money, that's not in itself a good enough reason for Medicare to make payment beyond timely filing or to issue that particular waiver. We have done, as I mentioned, some webinars on this topic. The recordings of those are available out on our YouTube channel. All right, so then the next few slides really just kind of reiterate things that I've already talked about. So I'm going to move fairly quickly through these. I do encourage you, if you have questions, to put those into the chat. It is 10:45 now, so the likelihood that we'll have time live today during this presentation is not good that we'll be able to answer questions live, but we will follow up with any question you submit for 7 days following this webinar, or those that are unanswered that you've placed into the chat. We'll make certain we get either a direct response out to the learner or a list of questions and answers out to all of you. Modifier issue fixes right here. Verify. When I say fixes, I mean fix it, resubmit it. These are rejections. Required, make sure that if a modifier is required, you're sending it. Make sure your modifier matches the procedure code. Certain modifiers only go with certain kinds of codes. For example, certain modifiers can go with evaluation and management codes, but not surgery codes. Make sure that the modifier reporting is valid on the date of service. I'm going to show you really quickly here. For modifiers, we get a lot of questions about the use of modifiers. We've done numerous webinars. I do want to show you on the WPS website that I've just pulled over. You should be seeing it now. Under the Claims Topic Center, go to Topic Center at the top, followed by Claims, select your particular jurisdiction. Scroll down the page under Claims and you will see Modifier listed and Modifiers. If you open that link for Modifiers, you will see links to many different modifier fact sheets that explain modifier usage for WPS. This tells you appropriate uses, definition, appropriate uses, inappropriate uses, what you need in your documentation. This is just one example, but most of these are set up very similar. Okay? Gives you manual instructions. Where does it say? Where does CMS say the requirements for using this modifier? We've linked them. So that is modifier information. Modifier fixes. Place of service, I talked about that out on our website. We have the list of place of service codes. Show you how easy it is to find things on our website. Pull up our website. I'm a searcher, not a navigator. Could just start keying in what you're looking for. Here are our place of service codes for professional claims. Okay. So again, resources on our website. Make sure you keyed it correctly, that the place of service matches the procedure code. You can't do a major surgery in the patient's home, for example. That's going to cause your claim to reject. The place of service doesn't match the procedure code. Make sure your place of service is valid on the date of service. Here are our patient eligibility fixes. Make sure that name and MBI match. Make sure you're submitting your claim to the correct payer. If the patient's a retired railroad worker, you're going to need to submit his or her claim to the railroad board. If they have selected Medicare Advantage, Part C, send it there. If they are a retired coal worker, send it to the United Mine Workers of America. Make sure you're checking that card for any identifiers, and make sure you're using self-service tools to check eligibility. Provider number fixes. Make sure you're entering those numbers correctly. There's no keying errors. You might need to contact provider enrollment to make sure that your records are up to date. Make sure your rendering provider is associated to your billing provider. So if a clinic is billing, make sure that the provider is associated in your provider enrollment records with that particular clinic. Make sure ordering provider information is entered on the claim. Avoid those dupe denials, folks. Don't auto resubmit without establishing status. Make sure you're billing appropriately. Of course, appropriate modifiers can also help avoid duplicate denials. There are some specific modifiers, those that are for a repeat procedure, for example, that might be the case where you would need to submit an appropriate modifier. MSP, we've talked about a little bit, Medicare secondary payer situations. Make sure that you're, you're doing your due diligence to find out if there's an insurance that is primary to Medicare. If so, report that on the claim and make sure that you're filling out every item on that claim form that's required to be filled out if the patient has insurance that's primary to Medicare. One of the tools that I want to show you before we do go today is the Crosswalk, and that's just a short name for it. Once again, I'm going to pull open the WPS website. This is the home page. Under quick links is EDI for electronic data interchange. That takes you to our EDI web page. If you scroll down, choose Medicare EDI. We have TRICARE, we have our commercial line of business, but we're talking about Medicare today. Scroll down and you will find those companion guides I talked about earlier about when your claim comes in the door and you want to make sure it makes it in, those pre-pass edits. But right here is the CMS 1500, which is your paper claim form, to the 5010, which is your electronic claim form Crosswalk. And this particular tool is one that our EDI staff designed. The information here tells you things. It goes item by item on a paper claim form, starting with item number 1. Gives you the narrative, what it is you report in item 1. If you're reporting on a paper claim form, where do you put it? It provides the data element description and the requirements for version 5010. This is your crosswalk, folks. One thing I want to point out is the status column. Some of these are R's, some of them are S's. You might be saying, well, what does that mean? On the crosswalk, we've included the key. R means it's a data element that is required in order to process a claim, such as the date of service. Situational means any data element that must be completed if other conditions exist. So situational. So this, folks, if you're not filling out a particular item or section on your claim that has the R here, that makes your claim unprocessable. It's rejected. You'll need to fix it, resubmit it. All right, MSP denials. Here are some MSP resources. And again, in the interest of time, I am not going to open all of these. I've just taken tons of resources so that you can avoid these rejections and fix these claims, resubmit them, and then of course avoid denials so that you don't have to request those appeals. And again, I didn't really delve deeply today into the appeals process and how to appeal those denied claims, but we have a lot of great resources on our website that speaks to that. National Correct Coding Initiative edit denials. Excuse me. We did have some denials, those MUE denials that I talked about, medically unlikely edits. Of course, keeping in mind that the Medicare unlikely edits, some of them are confidential, so Medicare doesn't publish the maximum units of service for every single CPT code or HCPCS code, but for most they do. This information tells you how to look up those edits. And it provides all of the different edits. We did have some issues today with add-on codes, so of course you might want to take a look at these add-on code edits as well to see how they work. Here is the information about avoiding those timely filing denials, and this is that the resource that I talked to you about. That article or resource out on our website that speaks to timely filing of claims. This is that part that I had mentioned earlier that specifically says a third-party error in making a primary payment determination does not constitute good cause for the purposes of reopening an initial determination. So that's where it says that, sorry, we cannot allow the waiver for this third-party error. Just some good information for you. We are trending down for your specialties, so thanks to all of you for your diligence on that. This is included to avoid those G2211 denials, that visit complexity code, that add-on code. that I talked about when you're the focal point for that particular patient's care. You know, verify your documentation is justifying the use, making certain you're billing that primary code, because this G2211 is an add-on code. You can't report it without the primary code. So I've included some resources for you here. More resources and tools, just as I promised I would give you. This is the requirements for processing the paper claim form, and then I've linked to that crosswalk that I showed you how to navigate to. The IVR is that voice and telephone keypad system that you can use to find claim status and details 24 hours a day, 7 days a week. That's with limited functionality outside of our normal business hours. We have an IVR operating guide that provides for you instructions. And similarly, our Secure Net Access portal has a portal user manual. If you are on the WPS website, I'm going to scroll back up, go to the home page, show you that right under the login, where you log in to SNAP, is a link to the portal user manual right here. Also, if you scroll to the bottom of any WPS web page, you will find a link to the portal user manual, illustrations, and step-by-step instructions for all its functionalities. If you are viewing claim details and you see a line that denied, the Secure Net Access portal gives you the option of selecting a button. I know that it used to be called More Info. I'm not sure it's called the same now. I believe it is. Click on More Info and you'll get even more details about why that claim line denied or claim. So for example, if your claim denied due to we don't pay for this service for this this condition, that's a medical necessity issue. That tells me, or it should tell you also, that means there's a policy. Okay, so then you'd want to look for the policy. If you're using SNAP, you can push that more info button, and typically it will give you an opportunity to link directly to that policy. So some great functionalities there. Website resources, how to reject or how to correct a rejected claim. This is a resource or an article on our website that tells you all of those reason and remark codes, or many of them. If you have a remit and says your claim rejected due to this particular code, look at this article, find that code, tells you how to fix it. Similarly, for claim denials, we have the same thing. We have those reason and remark codes, but we categorize them. These are reason and remark codes for bundled claims. These are for duplicate claims. These are for global surgery rules, and so on and so forth. You can look at this article or resource, find your reason or remark code based on the category of denial, and request your appeal. It'll tell you what you need to do. Our website, live events, Encore Presentations webpage, all have helpful information. If you are a provider that submits NOC codes, not otherwise classified codes, to Medicare, here's a link that tells you what you need to submit. This takes you to our YouTube channel, including some of those great recordings that I talked to you about, those videos for Medicare Advantage, E&M services, and so forth. CMS has great resources available. They have a fact sheet called Checking Medicare Eligibility, which will help you look up eligibility. Here is that tool, folks, that I told you I would show you or mention to you, that tells you or will help you know where to submit your claims. This Review Contractor Directory interactive map is a map on the CMS website where you can click on your state and it will pop up for you and tell you who is the MAC, who is the the qualified independent contractor, who is the railroad board contractor, and so on and so forth. So it's a great way to find where you need to submit your claim. That place of service code set is here. We had some rejections or denials, I can't remember which, a little bit earlier because the ordering or referring provider was missing from the claim. This is a link. This order and referring data set is a data set on CMS's website that lists all providers that are eligible to order and refer services for Medicare. Provides the contact or the identification of and provider numbers for reporting these services on a claim. So good information. The coverage database is the CMS searchable depository for policies and articles. You can also look at the WPS website homepage. Click on the icon or the logo on any page to get back to the home page. This code lookup tool on our home page, you can choose an LCD or article lookup and enter a code, title, or definition. Click on search to see if we have an LCD, local coverage determination, or article for that particular code, title, or definition, or if there's a national coverage determination for that. This tool, how to use the Medicare coverage database, tells you how to use it. This is where we would normally have questions and answers. We are right at the top of the hour now. So once again, I will let you know in just a minute how you can submit those questions to us. And of course, if you've already entered a question into the chat, we'll make certain we get a response to you. Now, if you are one of those learners who is seeking continuing education units, in just a few minutes, you're going to receive an automated email from WebEx. It's going to thank you for attending. If you need CEUs, do not delete it without reading it. That email contains your certificate of achievement, and that's what you need to submit to an accrediting body of your choice in order for them to consider awarding you with CEUs. Now, if you don't see that email, check your spam or junk folder. If you find it there, make sure that you add the WebEx email address to your safe sender list. It's at the bottom of this particular slide. Now listen carefully. If you joined by phone only, if you listened only to this webinar today, WebEx will not send you that automated email to thank you for attending, but we do thank you for attending. If you need a certificate of achievement, send an email to our education mailbox. The email address is here on this slide at the very bottom, also on the next slide. It's also up on top here on this slide. Include today's date, the name of this webinar, and yes, you can abbreviate, and your telephone number you called in. We will check our WebEx records and verify your participation, and then we will manually send you that certificate of achievement. Now again, if you get the email, use the email as your certificate. For those who are listening only by phone, we will manually send you that certificate. Here's how you can send those follow-up questions. If you've submitted one in the chat we haven't already answered, please be assured that we will answer it. Send any questions that pertain to what I talked about today, not claim specific, to WPS's education mailbox. The email address is here. Place Common Part B, Pulmonary Disease Rejections and Denials in the subject line. You can abbreviate. And we will get those answers back to you. We're going to save all the questions up for 7 days, and then we'll respond as soon as we get the answers to all of those questions taken care of. I mentioned this to you a little bit earlier. Please take a few minutes now to complete our survey. Tell us what you liked, what we could do better, suggest topics for future education. This program today was specific to data. If you want more information on types of denials, let us know that when you complete this survey. Your feedback really is invaluable. It ensures our education is timely and effective and getting you what you need from us. So this is so very important that we're going to give you another chance to complete it. When you exit the webinar today, you'll be redirected to the CMS Qualtrics page for the survey. It's going to look like what you see at the bottom middle of the page here, that little external site with the triangle there. It's okay to go to that site and complete the survey if you have not already done so. On behalf of myself and Karen and all of us in provider outreach and education, I want to thank you for your participation. We do look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a wonderful day.